Hello, welcome again, and I'm Dr. Sridhar. We have with us a very special friend of mine, and he has kindly offered to spend some time with us, especially for the young folks among you. Dr. Naveen Jain doesn't need any introduction. So, obviously, we trained together in PGI, and we will have a small chat about that. But he is the lead neonatologist in KIMS in Trivandrum. And I can add that he's the most popular neonatologist there in Trivandrum as a whole, I think. He is also the editor for the South Asian edition of the Cloherty, which all of you would be reading, I'm sure. In addition to Illingworth, the development of children, I'm not saying the right name, but Illingworth Child Development. And he has contributed so much to neonatology in India. He's the chair of the NNF examination board as well, and he's a passionate teacher. I mean, many of you may be his students or have attended his lectures. I have many interesting stories to share for our time together. And welcome, Naveen, and thank you for sharing this time.
Yes, Sridhar, I think the best part is being able to talk to you for
Yeah.
next half an hour.
Thank you so much. Amazing. I mean, just a quick recap. I mean, I was completing my first year when you and Amchu joined in PGA. Dr. Amchu is now a consultant in Calgary in Canada. And Naveen came from Trivandrum. He already had a great reputation because my professor in JIPMER, Professor Srinivasan, was his examiner, and or I mean, he has seen him in some exam, and he was so impressed with Naveen. So he told me how meticulous he is. And in PGA Chandigarh, we have a very rigorous routine, and there is a grilling on every morning round. The previous day's cases are presented by the senior registrar or the DM PG, and he has to defend whatever actions he did in front of the other DM students as well as professors. And we were very lucky to have the great teachers, Professor Narang, Professor Praveen, Professor Saurabh, and Dr. Kanya. So all of these great professors, I mean, gave us the culture that we have now and the passion for learning and teaching. But in addition to our, constant engagement at work, I mean, Naveen has fed back to me that I was a good support to him. I'm very happy to hear that, saving him, protecting him a little bit from the attacks in the department. But in terms of, that's a fun word. I mean, it's not really attack, it's more a push to learn more. But in terms of fun as well, we had a lot of fun together. I mean, I think one of the anecdotes is the Shimla trip, where I mean, my wife was in India at that time, and she was doing her final year PG. At that time, I mean, me, Naveen, and one of the pathology students, pathology residents, Mani Subramani, we went on a sudden trip to Shimla, and we stayed with one of our patients' family, and it was snowing. It was an amazing experience. So I still haven't told Vidya the real reason we went. So if in case she watches this, which I'm sure she wouldn't. So do you want to add anything about her PGA
Yeah,
memories?
it was a lovely experience because just like Sridhar ji said, we had moved from a good working culture, a warm working culture at post-graduation in SAT Hospital Trivandrum to a more commando-like training at the PGI, which at that time sounded very tough. But when hindsight, we see that it was that what brought better out of us just now. But to be very honest, first few weeks it was unimaginable in being rigorous. And at that time, Sridhar ji had one thing very a common thread that we both had not been graduates of PGI, so we were outsiders as they used to call it, and or state college products who were really uh, not ready for the kind of grind that was there. And at that time, Sridhar had started even before the exam. Every one of us who took the exam on that day walked to Sridhar's room and asked how to prepare for the exam. And then after that, after joining the course, every evening, including telling me that G6PD in Punjab is different and don't trust what you saw as bilirubin in the morning, it would be totally different in the evening. From telling me where to buy vegetables and how to survive in Chandigarh. And of course, going to that lovely skiing photograph that I had, and my wife saw that photo and she thought this guy is great skier. So there are lovely things. Yes, it was nice. Yes, thank you, Sridhar.
Thank you. And I mean, as you rightly said, we were lucky to train there with, I mean, Dr. Narang had the vision and Professor Baku as well that they brought in the Western setup to India much ahead of time. I mean, now all of you are replicating it. And obviously, the way we trained was rigorous and meticulous. And the beautiful thing was the stress on physiology. So, what I try to teach the students these days is the baby is there to be supported. So they need a little, they're not diseased itself, it's just the adaptation. And you need to understand the physiology and support them through that. So I think you follow the same principle. I mean, I've heard from many of your students as well. So don't overdo things and try to just realize what's happening and support the baby to come over what they're going through. Most of the time, you don't need to do more than just a nudge. So that was the stress on physiology. I mean, if you have any presentation, you would go through the oxyhemoglobin dissociation curve or any of the stress on fetal medicine as well was quite high. Dr. Sarla Gopalan and Professor Narang had a very good rapport. So that was great. I mean, I have very fond memories of the time together, and that's why I brought it up. And I'm sure the students who are new and who are training don't hesitate to work hard because we were, I mean, overawed in the beginning, but obviously when you go through that, you realize that you understand much better and it imbibes into you. It becomes a reflex when you make decision making. So, Naveen, I mean, first of all, congratulations on the great publications and the great work you're doing in terms of publishing books. And I mean, being an editor of a widely read manual like Cloherty, which is like a Bible for many of the students, is not an easy job. And I have had a chat with you on how much time you spent, like almost 1 year that you didn't really sleep well. So, do you want to just give an overview of how Cloherty can be used by the students and what your experience was about this?
Yeah. Yes, Sridharji, the first edition of Cloherty that we brought out as South Asian edition was meant to be just an adaptation of the international one, where we had to add in content which would be relevant to South Asia. And we were requested not to make changes in the major text. So that first edition was a little easier for completion, but was not satisfying to me. When it came to the second edition, they told me that by publication rule, we can change major content of the book. And for those who see, it was not only the content of chapters, even the chapters changed. So we had several new chapters into the book. Now, what the driving force was, initially, I was, to be very honest to whomsoever is hearing me, is that I was very reluctant in thinking that uh, is this a chance finding that or chance happening that I'm getting to edit the Cloherty and am I right person for this job? It was very much there in the back of my mind. But then I thought there was only one reason I thought I was the right person. A is because I was still practicing with my hands. And B, I thought I was not the most celebrated, intelligent publication person in the group. So I was not the most research-oriented guy. I was working in the wards in ordinary hospitals, and so I thought that the way I think will probably reflect what most people need in the book. So if you're working in institutes like where we train, PGI, Chandigarh, JIPMA, you have a whole lot of intelligentsia, daily discussion on academics at the top level, and the kind of resources flowing in, the kind of patients you manage is at a different level. So I thought that being at a level 2 in that sense, that working in hospitals where everyday neonatology was happening, I thought then this would be a chance to do it. And the driving force in the book was a consumer like me who wanted to read a language, maybe you can call it Indian English, that was easy to read. And since freedom was there, we took off a large part of the content which was theoretical, large part of the content which was not
US
being done.
oriented. Yeah.
Yeah, yeah. So that was what was the driving force. But that's why it took time. The editors had their time pressure. They wanted us to finish the work. They have their deadlines to meet. But I was not willing to sacrifice. And this is a true fact, Sridharji, that for almost a year, it was almost 14 hours a day with only Cloherty, and clinical work had to go on because I had to be paid for my job as well.
Yes, I mean, obviously you have done a great job, and I don't know if you're aware, but I'm the mentor for a fellowship program called Medigrad, and Cloherty is a key manual for that. And I get great feedback, and most of my lectures are based on that as well. So thank you for the great work you're doing. And as you rightly said, I have the same advantage of having a different perspective from all areas. Like I worked in India, I worked in UK, working in the Middle East in different levels of units, and also the general pediatric exposure. I see children for 3 4 years, so I do see the follow up. So it's not just the NICU based, and sometimes the our colleagues who practice in the community need that as well to some extent. And as you said, the felt need of the practicing neonatologist or pediatrician is what guides you, and you are the right person, no doubt. And not everyone can put in that effort, and I think Neetu and your family have supported you a lot in managing that as well. I mean, it's not easy to spend so much time on editing the book, and the outcome is good. What about Illingworth? I mean, that was a fun book to read when we were doing our post graduation. So what would you say about that?
Illingworth took much longer because it was something that I enjoyed. You may remember that when we were doing DM,
PhD,
I
yeah.
requested Dr. Naran, can I go and learn Bailey scale? And he wondered what a neonatologist has to do with Bailey scale. So somewhere development was there in the heart.
Hmm.
And when I came back, my mentor, Dr. MKC Nair, he gave me some work and he realized that I enjoy this work and he kept giving me more and more work. So for two Illingworths prior to this edition, I was doing ghost editing, as they call it. I was helping MKC sir with editing the book. For the previous edition was done by him and Dr. Paul Russell. But he said we will not be able to acknowledge your work. And it didn't matter to me at that time. I was enjoying reading that book. I was enjoying trying to help. And then when the book came in for major edits, the major concern that his daughter had was uh, they wanted English to be impeccable because they didn't want editing to be done by a person who cannot
So first
be
language isn't English.
writing well.
Yeah.
So, and they don't respond as fast as we do, that I send a mail and you get back in 5 minutes. So it took 4 or 5 months for us to submit a few model chapters. Uh, and then madam just said, this is fine, I'm okay with it. And then I asked for a permission for again a major revamp of the book to add uh, content for application. So the previous Illingworth was actually a better book to read in that sense.
Mm.
It was a lovely read, the stories of Dr. Illingworth, learning the journey of neonatal child development. But if you see, that book was just ending abruptly many times, saying that this is what I have seen.
Yes.
He never wanted to give a manual for what you need to do with these children.
Mm.
And as again a practicing person, I wanted to add some sections on that what to do I do if I land up with a child with developmental problems.
Mm.
Being a neonatologist, you would see a lot of chapters being oriented to neonatal work now. But that book took almost 3 years to
Mm.
edit. So after the work got in, because we had to read, and just as an example, I can only give, we all grew up doing a good enough draw man test, and exams, many candidates might have failed their exams because they couldn't do the good enough draw man test.
Mm.
But when I started doing in-depth reading, I realized that good enough draw man test had become obsolete 20 years back. And because of its lack of predictive classification of good and bad.
Mm.
And the same with neonatal reflexes. I know even now candidates fail examinations for neonatal reflexes. But the youngest age at which neonatal reflexes have been used for any developmental team is at 5 months of age by a group called Capute and publication. So it was hard work required to refute what was already discussed in all standard textbooks, which had probably based it on Professor Illingworth's work.
Mm.
And I'm really thankful to the family of Illingworth to allow me to make the changes that I requested. And the book was remodeled completely. In fact, there would be hardly 50% of the content which you will find from the previous Illingworth. So the lucidity would not match what he could write. He is one of the greatest. So what I did is all the quote unquote part of his stories or messages or what you would call as the elixir of neonatal development. I pulled out, and as per the family's request, the whole book is in two fonts if you see it. The fonts which are italic are which are original words of Professor Illingworth, and the family didn't want a reader to confuse my edition as their father's work.
Right.
So whatever is in what looks like straight fonts is probably practice pointers from contemporary days from a neonatologist viewpoint. And the elixir of development of understanding what we have, which, and you figured that he talked about genetics of development at a time when there was no whole exome sequencing and no access to any genetics.
Yeah.
I mean, he is something which I would feel ashamed to say that I've matched in editing, but I learned from the book and I could just add some part for practice into that book as well.
Be a little more clinically relevant and more
Yeah.
to the practicing physician. In terms of training, you have, I think I visited your unit in KIMS in 2011. That was, thank you for the kind invitation. It was a one-day arrangement from Chennai to Trivandrum and back. So it was a great experience, and you were just setting up the training program at that time. I think it was your second or third year in the job. It was a new hospital, and you were already started the DNB, and now you have DNB and fellowships. Do you have DM as well now, or the DNB neonatology?
It is DRNB, it's called now, but it's just the same as DM in terms that NMC has made them equal, except that DM program happens in larger public health hospitals with far higher patient load and far more senior teachers at one point of time. But today we can be happy to say that I have 6 colleagues as good teachers. So from faculty point of view, it is good. Patient load will never match what a public health hospital can have.
Yes. And you have how many students now?
We have 3 DRNB students per year, so that makes it 9. And something like 2 fellowship students, and pediatric residents do rotate for a short. So you would have 11 trainees at any point of time at least.
And the pediatric, you have DNB pediatric students who come to you as well?
Yeah.
Yeah, they are gone. So the DRNB is amazing. How many years you have had that?
From 2008 onwards, so now it is about 17 years now.
No. And some of your students will be teachers as well. Like
Yeah,
this.
yeah, all of them. They are all doing very well, and they make us proud as well.
Yes. And do you have any tips for the young students, what they should learn and how they should approach their dissertation projects and things like that?
I will, with permission, borrow what I learned from you, Sridhar. I'm not saying this because this is an interview. I realized that you had a very pragmatic and practical approach to learning, and we got something from everybody. And I think I felt at that time that anything that I see on the floor, whether it is a diagnostic or therapeutic, I must go back home and I should know what I'm doing. I remember you from helping us to thread that heater wire into the circuit onwards to even asking that why the CRP has to be done this way, why controls and everything there. So I think the first tip I would give is, if you look at the literally meaning of the word doctor, is something that we administer. And I have always prayed that any diagnostic tests that I order or any therapeutics that I order should not harm a patient or should not be a major miss, because of the training that we happen to become the last stop for neonatal sick families. So we should learn what we see every day. That would be the first step, I think.
In terms of, textbook learning versus journal, they are quite confused these days, and so many online resources as well, so which can be misleading at times. So how do you guide your students?
They must stick to one textbook and stop living in the fear that the textbook will be incomplete or it would not be updated.
Yes.
I have to tell my real experience. As the exams approached in DM, we had to take it at 2.5 years. So last 6 months, I worked hard on downloading new content. Those days it was not easy. Neither internet was easily available, nor you had large hard disks to save content. So, but I downloaded all the PubMed content that was available to me, piled it up together, tried reading it. It was huge amount. And after that, when I went and read the chapter from Avery, I found everything was already there. So the 80% of content that you need to know is already in a book.
Mm.
If you manage to finish reading the book, at least on areas which are clinically relevant, everyday practice, then only please go and search more on internet. There might be some content which is very contemporary, latest, new, that may not be there, but maybe you can spare 20% of time closest to examinations to master that. But 80% content should be a standard content reading from one book. Don't read three books also.
It's agreed that, I mean, the journals can give you what is updated, but you get the foundation right from reading a textbook because you're starting from scratch and building up. And that kind of an approach is important for you to understand what we discussed initially as the physiology or the pathophysiologic approach to disease management, because you may know all the newer treatments. And again, if you are bringing up something controversial in the exam, which is not really, I mean, in current practice or the examiner thinks otherwise, I mean, you're safer in following a textbook to get the foundation. And once you're a practicing clinician, probably you may not go back to the textbooks as much, but it's still a good idea. I mean, like in US, they have the recertification, so they always read the books again after 10 years, and we don't have that in UAE or UK or India. But you yourself can start looking at revising for any reason. I get many questions about dissertation choice. I mean, how do you guide the students? I know, I mean, Murki, our dear friend, is amazing in terms of organizing studies and thinking of many projects. But how do you suggest the projects? I mean, what's your approach?
We've had both type of research work done. Uh, some of them are what I call as pure clinical research, which are very easy to do in terms of requirements of resources. For instance, you could have a project when you recently we are trying to do one where we're trying to do a nested case control on trying to see whether adverse neonatal outcomes that we are seeing have to do with exposure to blood products over the last decade. So that can be a very clinically simple project where you don't have to do things different. Once in a while, we do get very fundamental questions to mind. We imagined and dreamt that the parental nutrition amino acids we use um, are the same whether you're dealing with a 23-weeker or a 29-weeker, whether you have a baby with renal dysfunction or hepatic dysfunction, and whether the baby gets it for 1 day or 15th day, 20th day. And if you're creeped up in mind that do we land up getting any amino acid into toxic levels, and that the outcome that we're measuring in terms of development is very distal in terms of just growth and development. So we did biochemical studies in trying to see the levels of amino acids after 1 week of parental nutrition. So that was a very tough study for our resident to do because he didn't have much references to fall back on, at the risk of a reviewer questioning in many ways. But some of the researchers, but at least frame a clinical question into PICO and ask, do you have the population in terms of numbers or events in your organization where you're going to do the research? Would the intervention require cross-department approaches? That is very important because when you start research, if your core department is not ready to go in sync with you, the student might have difficulty. So it is always nice to give students work which they can do within the department. And outcomes also should be either clinically relevant to the patient, they are respected, and maybe they should be easy to measure without requiring too much follow because that is very challenging. So these have been some of the thought processes in trying to
According
get
to their
students.
level of interest as well, a pragmatic approach. And I'm seeing a lot of feeds on Twitter about questioning whether the research should be compulsory as part of training or you leave it to those who want to be academics in their career. So, of course, an understanding of research is important, and you need to be aware of how to analyze the literature and which publication is suitable and so on. But in terms of uh, conducting the research, the dissertation we do most of the time is more for namesake. So whether that process can be done away with, but it's not clear yet. So, I mean, you are in a referral center and you see many babies coming from outside units in addition to your inborn cases. Uh, I mean, I see many messages on my YouTube channel from parents or from colleagues who are asking questions, which are fairly basic mistakes, and I tried to make videos to correct those, but I'm sure you are seeing a lot of that as well. So again, to the practicing neonatologists or pediatricians, can you give a few examples of what they can correct, or what common mistakes you see that you would like to correct?
Maybe it will be a two-part answer. Maybe in the last 5 years, we have had a very large number of trained neonatal uh, fellows, trainees, people who went out from almost 50 of them from our own center, and another 30, 40 coming back from institutes like PGI, AIMS, JIPMER, and from fellowship programs elsewhere. And I think they're well trained. So in the last maybe 5 years, the what can be called as message to friends would be different from what we saw earlier.
Mm.
Maybe 5 or 10 years back, the major gap you could say was not believing that neonates can make it when they are premature or sick.
Mm.
So if I say when we started in 2003 to something like 2010, most of the babies we transported, the number was very huge at that time, something like 75 to 100 transports per year. And I was the only person going for those transports by myself, bringing them back, is that we were picking up them a little late when there was probably pressure from within the institute or from the parent that we want to try and save the baby.
Mm.
Most of them were actually bigger babies at that time. They were meant to make it, and they require only a little care, little more care to survive. And that's why I think the initial journey was easier as a clinician to repair these babies.
Mm.
I had heard this from my teacher and friend, Dr. Karthik sir, that 15 years down the line, uh, people will stop clapping for you and they will start asking you fundamental questions that why didn't a 24-weeker survive?
Mm.
It was happening all the time earlier. And I did see that change. So in the last 10 years, we probably have started seeing more complex cases. And the fundamental problem remains the same both within us as well as in referring people, is sometimes not knowing what can be done today.
Mm.
So sometimes we can have the feeling that I can do this here, ventilation. The same ventilator, I have the same ventilator we have in the other place. I have the same meropenem available to me. Why don't I try
Mm.
before we refer a patient? Whereas I think what we benefit from is what any other high volume unit benefits, that the nurses, the doctors, the labs, all of them are tuned to sick babies. And it is not better science or better intelligence that brings better outcome. It is, I think, the well-oiled machinery with when I'm talking about 9 plus 2, 11 trainees. I think my unit has a era when we didn't have trainees and an era after we had trainees, and the outcomes have become exponentially better after they have come in. So I think believing that a baby may have an option to make it, in spite of having so much WhatsApp today, even now sometimes communications are less than what they should be before transfers happen. You have worked in UK and you remember how much handover happens very clearly, written, verbal. We also try, I can't say we are half as good as that when we refer back also to call and say that I'm sending a baby back whose care is not completed.
Yes.
And so I think this two-way communication process has to happen more often.
Is there any system to educate the ones who are referring to you to refer earlier or to do things better than? I mean, do you have a way of, or people still defensive, or they're open to feedback?
So Kerala is better there in that, Sridhar. We are not getting late referrals in medical terms.
Yes.
They don't sit on patients because both patients are educated and so are the population of medical people are very highly trained in Kerala, or very civic sense is far higher. But what is the delay is in not knowing what can be done. It's not the lack of intention, and therefore the way forward is probably um, case discussions
Yes.
and uh, case series discussions rather than case discussions to let you know that, okay, when I came back from PGI and the first baby was born with PGA in our unit, you know that we were not able to save many congenital hearts at that time.
Mhm.
My in-house cardiologist, Dr. Ramakrishna Pida, who had worked in Middle East for a long time, he just walked very quietly and said, "So let's just do a procedure." I
Yes.
said, "But sir, we have never done it there." And he just brought the ultrasound machine, passed a catheter to the,
Trust me.
uh, and the baby was better. So this was first time believing. And then when I started speaking to Krishna Kumar sir and Balu, my friend in Amrita, I figured that they had 98.5 survival with well transported antenatal or postnatal congenital hearts, except for HLH.
Mm.
So it was an eye opener. And before that, I would have been guilty of probably guiding a few families in saying that congenital heart, do you really want it? Body language itself is different.
Yeah.
So I guess that conviction has to be passed on correctly that small and sick babies can uh, make it. And they are probably not delaying referral. They probably just are not believed and seen enough.
Yes.
So things have changed so fast that in what I and you are seeing as neonatal practice today would make us look like barbaric what we were doing 15 years back.
So, I mean, in terms of the key message is to know the limitations and also be aware of what people have around you so that you can counsel appropriately. And also, in utero transfer is probably better in that setup as well. If you have the facility and even 24, 25 weekers, if you have the option to refer them, it's possible. And close communication, as you said, I mean, there is nothing holding you from improving your practice by messaging the tertiary center and getting a feedback so the baby is in a better state other than would otherwise be. So, I mean, in terms of, finalizing these, I mean, your advice to the peripheral pediatricians, I mean, do you want to have any tips for them apart from this?
Uh, I think if it's a two-way referral, there is two benefits. One is that uh, they get to see the continued care process of the sick babies that they have referred to us. And the patients also start respecting them as their primary doctor because not every patient can keep coming back and forth from one city to another. So I think we also have a responsibility to make sure that, because many times in our region in Asia, that if a patient couldn't be managed successfully in one center, then the patients don't want to go back to the same center. They think that the center failed. What they don't realize is it's not the center failed. There are different levels of care that are possible in each setup.
Yeah.
So I think the two-way referral will be a society building process as well as a two-way learning process. And there is no way to do. When we were starting transports, initially we tried creating templates saying that this is the minimum you must fill in before you refer a patient and things like that so that the care is complete. But I guess the only way forward is the flow has to become two-way. If we start referring back patients to them, uh, making clearly safe that where they came from, then they will start believing and they will get the community to also accept this two-way process.
We have to overcome some logistic issues like billing and so on. But obviously, the parents also have to agree because they've seen your unit and you're more confident. Just before we close, I mean, you are in charge of the NNF exam. So, my point is in terms of the fellowships, are we taking any steps to make it MCA recognized? Because I know it's a useful tool and you're doing the exams in a rigorous way. The shadowing is done in busy units. So, I mean, it's not the same as DM or DRNB, but at the same time, they're better trained otherwise. But is there any chance of getting it recognized, or they need a 3-year program to be recognized?
There are two fellowship programs happening parallelly in India now. One is under the IAP, and they have at least have had a central body called Indian College of Pediatrics and taken all the fellowship programs under them, including neonatology also now.
Mm.
And for last 2 years, they're conducting an entrance exam to uh, take candidates in,
Yeah.
unlike what used to be that centers used to select candidates, and they are trying to have uniform processes. I don't see immediately this getting to the MCI. One of the advantage of fellowship programs or not being under MCI is something similar to what you may know better than me, is the unstructured fellowships or exposures to subject which are there in rest of the world, where they neither have an entrance process nor a really exact exam. They don't even want to give you a certificate. You are actually learning a subject for a year or a year and a half in a center where training is happening. So I think one of the advantages not being under NMC is that uh, we are not trying to replicate the process of certification. So when they come to learn, they are mostly learning what they need to practice rather than what they need to do to
They
pass an
do have an
examination.
exam in the end as well, right?
Yeah. Yes, a centralized process, and it is surely not.
Unified now, there is no separate IAP and NNF fellowship.
There are separate fellowships and there are separate examination processes,
Okay.
but uniform. But the structure of examinations is more or less similar
Okay.
in terms of the type of questions that are asked in theory and the type way the practical exams are conducted. There is hardly any difference, and mostly even the examiners are of similar thoughts, and you might see the same names on both the sides many times.
Only advantage from
So
recognition from MCI would be the medical legal aspect. I mean, I get asked this question, I mean, whether the pediatrician can manage neonatology, and my answer is level 2 neonatology can be done by pediatricians. And if you have additional fellowship, it's going to benefit you. But level 3 should be left to the fully qualified neonatologist. So would you agree with that kind of approach?
I think that has to come from internal audit itself.
Hmm.
And more than the type of degree they take, they must go back and see in what kind of a system they're fitting in. So suppose somebody does fellowship and goes back to a high volume unit which has maybe 5 consultants and all the support services that you would require from cardiology, neurology, metabolic services, MRIs, then they could just practice with the team,
Yeah,
whatever high-end work is.
of course.
But if you go back to a one-man service, which is very helpful, it really helps a large number of newborns. But I always ask my fellows at the end of examination and say, this is not going to be scored. But if you have a 24-weeker who is going to get ventilated on high supports for 2 months, are you not going to go back home, or you're not going to take a bath, or you're not going to celebrate a birthday? Because I've seen all this happen in the first years when I was doing a one-man
Yeah.
show, that you even take the cell phone to your bathroom. So you don't want to do that kind of practice. So unless you have a team
Yeah.
which is large enough to back up more than the fellowship. The advantage fellowship had, I think, Sridharji, is that they went back to towns, districts
Yes.
where these highly trained people were not willing to go back to, and they're not still willing to go back to. They still want to go back to large corporates in large hospitals or teaching hospitals. So one of the advantages proliferating fellowships, which may be not completely monitored or may not be of that level of
Mhm.
uniformity, is that still I think many things they have made safer. They're using less antibiotics. They are monitoring for hypoglycemia. They don't allow bilirubins to shoot. They support breast milk. They want to do less invasive ventilation. They do more CPAP. So these are all things which have percolated to every
Hopefully
town now.
teach the people around them so that it cascades down as well in the periphery. We are seeing many students on the ventilation course who have done fellowships, and they're quite good. So, and I think the recognition obviously will push them to come into the cities, as you said, probably. So it's like a two-way process that we need to look at, and the numbers will be limited if you have a structured 3-year training program and so on. We have to find the balance. Anyway, I mean, it was a pleasure speaking to you, Naveen. I mean, thank you for the time, and hopefully we'll catch up in the near future as well. Congratulations on all the great work you are doing, and I think Dr. Neetu is also quite involved in development-friendly care, isn't it? So, do you want to say any words about her, or you want to share the? She has kind of parent support
Yes,
program.
for last maybe I can say 6 or 7 years, picked up great interest in something which is yet to get its full place.
Yes.
He's trying to understand that what a mother needs to be knowing, thinking beyond ultrasounds and hemoglobins, and that the way she handles her pregnancy
Holistic.
has a lot of bearing on what the fetus and newborn, when we know that it is true. But we still are very busy with trying to optimize that, the medical care. So I think that is going to come in sooner or later, where we try to understand that part of care.
Yes.
Besides that, I have to confess that um, one couldn't be a maniac working, enjoying, and doing whatever you wanted if you didn't have a partner who was willing to play a second fiddle in literal sense,
Yeah.
despite of being trained from the highly trained institutes like PJ herself. So if she had not played them, then I couldn't have been talking to you today also.
Thank you. That's amazing, and good luck to her as well on this project. So we will catch up soon, and thank you for sharing the time. I'm sure this will benefit a lot of young colleagues, and it will stimulate more people to. And I hope many people get the Illingworth and Cloherty to go through the South Asian editions to be clear about what you exactly spoke. Thank you, Naveen, and good luck.
It was a lovely evening chatting with you, and I wish it could have been without the phone in between, and we could have been just gabbing.
Yes, next time
Thank you
soon,
so much.
very soon.
Yeah,
Thank you. We'll catch up soon.
yeah, thank you. Good day.
Have a nice evening. Bye bye.